So, ladies and gentlemen, Honorable Minister Thar, I'm delighted to be able to speak to you today, and I apologize for the fact that because of commitments in Pakistan, I could not be with you in Washington, D.C. this morning. I've been given the charge to speak to you to try and convince you about the importance of maternal and child health in the context of Pakistan, and why is it important for our national security in the long term in the context of human development and action. This material that I'm going to share with you builds on our previous analysis over the last several years on trying to put the objective evidence of maternal child health and survival in Pakistan, both in terms of current challenges and also the opportunities that exist for improving the situation. If you look at maternal survival, Pakistan has made progress. And although we started off with perhaps maternal mortality rates that were fairly high, in excess of 500 per 100,000 births, today as we speak, from the best available information, including a large survey that was done a few years ago, we are down to where we believe our consensus figures are below 300 per 100,000 births. But these may vary in different parts of the country, and I will illustrate that a little later. In the context of child survival, the situation is perhaps also comparable, but only partially. So if you look at overall under 5 mortality, Pakistan has been able to reduce under 5 mortality, but still is way behind our Millennium Development Goal 4 targets of getting to around 41 per 1,000 live births. In contrast, as you can see, the slope for reduction in newborn mortality has not been as steep, and progress in that has been much more limited. To look at it more specifically from available national surveys, although we have reduced child mortality from 1990 by about 26%, our newborn mortality rates for this comparable period haven't changed, and that remains a big enigma in terms of why there has been so little change in reduction in this particular area of child survival. When you look at it a lot more closely, we find that by persistent efforts and by the improvement in our primary care programs, there have been gains in interventions and their coverage over a period of time. So if you look at antenatal care, if you look at maternal tetanus immunization or stillbirth attendance rates, these have gone up on an average from about 20% in the early 90s to what we believe is around 60-70% coverage overall. The same is also true for many of the important child health and newborn health interventions, including facility births, and including also access to things like cesarean section rates that overall at a national level now lie close to around 10%. There are some key interventions, however, where we haven't made progress or progress has plateaued, and those relate to things like postnatal visits and also importantly exclusive breastfeeding rates, which have stagnated at around 23-30% over the last many years. So there are a number of reasons why perhaps we have not been able to achieve the reduction in newborn mortality that we would have aspired to. One of those, not measured and captured on this particular slide, relates to what has been happening to population growth in Pakistan. So if you look at the clustering of these deaths, a lot of these deaths for mothers and newborns are around the day of birth, the very first day of life. And in addition to maternal and newborn deaths, we have close to around 100,000 intrapartum stillbirths, which are an extension of newborn deaths that occur also around this time period. Now, why I mentioned the whole issue of coverage rates of key interventions is because there is disparity in terms of where people are delivering. So this slide captures the district-specific rates of people who are delivering in a health facility in various parts of Pakistan. And as you can very clearly see here, although there are provinces and regions where a reasonable proportion of people, around 40-50%, still not optimal, are delivering in facilities. Look at Balochistan and parts of Khyber Pakhtunkhwa, where less than a third of the population delivers in health facilities. I mentioned population growth rates, and one of the important things to remember that in comparing 1990 with data today, and as you see for 2013, actually we have increased our total birth cohort from about 3.9 million annually to 4.8 million. So we essentially have 1 million extra babies being born every day because fertility rate reductions haven't kept pace with what is required optimally to stabilize the population and to reduce its rampant growth. And that probably is also one of the other important areas that influence the slowness in reduction of newborn mortality. You can see this also from the proportion of populations in various districts who have unmet needs for family planning. So commensurate with what I told you in terms of the disparities around skilled birth attendants and facility births, you can see very clearly that we have many Pakistans. We have Punjab, where currently a large proportion of the population has its family planning needs met. And then we have the South. We have Balochistan, where many people have no access. And we have Sindh, where the performance of the program around family planning access and coverage has been very variable. So let me move on. And beyond the newborn period and maternal care, a big issue in Pakistan is that disorders like diarrhea and pneumonia still kill around 120,000 children every year. And these are disorders that we have principally eliminated in many parts of the world as major causes of child mortality, even within our region. So if you look at the data for Pakistan, following the neonatal period, around 20% of all deaths in children are related to these disorders, which we should not have in our population, killing children the way they do. And there are several reasons for this, which I don't have time to go into today, including some of the social determinants around environment, around water sanitation and hygiene. But if you look at clear issues around care seeking and treatment provision, a large proportion of our population, and you will by now recognize these geographies and districts in the northwest and also Balochistan provinces, where a very low proportion of the population have access to care for childhood illnesses like diarrhea and pneumonia. And you see this in this particular slide from care seeking for diarrhea, and you will see this also in relation to care seeking for pneumonia in the same provinces and the same districts as being a source of huge disparity. And when you come to pneumonia, you'll also begin to see this happening for southern Punjab and parts of Sindh. So overall, over a period of time, from 1990 to the last time when we evaluated this at a national level, although coverage with antibiotics has improved, care seeking around many of these childhood illnesses has remained stagnant around 2/3, indicating the need and the opportunity for greater societal and civic society engagement. I also wanted to talk about some of the underlying determinants and to principally underscore the point that a big issue in Pakistan also relates to maternal and child nutrition. And these are quite closely interlinked, not just at a given point in time, but across generations. What do I mean by this? If you look at the data for child malnutrition, reflected by stunting, underweight, and wasting, over the last 60 years or so, Pakistan has made very little progress, unfortunately, in eliminating and reducing childhood stunting. And these rates overall at a national average are around 40%. But if you look at their distribution, we find that there are huge disparities. And all of a sudden, when you look at stunting as a measure, we begin to see parts of the population that would have hitherto in previous slides that I've shown you looked better, not look as rosy as they were. So you take southern Punjab now, and you have stunting rates which are fairly high as parts of Sindh. And you again have the whole area of the Northwest, Federal Tribal Areas, KP, and the Northern Territories emerging as principal hotspots of child stunting. And there's a very close correlation with maternal undernutrition. So if I was to superimpose on this slide a slide of maternal wasting as a measure, you would see that there is pretty close homology and that these are the very districts where women and children are malnourished together. In our recent analysis, when we looked at what determines stunting in Pakistan, these we just published a few months ago, you find that stunting in children, being of a short height, is related not only to maternal wasting like body mass index or poverty, but it's also related to how tall the mother is. And that immediately relates to the intergenerational effect of this, because if you're short as a girl and you're short as an adolescent and you're short as a young mother, then you will be at much higher risk of delivering a small baby who will remain short. So this is the reason why we need to invest in it over time. This particular slide is a rare slide because very few countries actually measure the rates of malnutrition in their young girls. And these are recent analyses that we have done, which indicates that in Pakistan, close to around a fifth of all girls that fall in the adolescent age group of 15 to 19 are stunted. Important points for us to underscore in moving forward. So I want to move forward and also cover one big issue around inequities in access and coverage that I've illustrated in some way around the geospatial maps that I've shown you. And it's important to also underscore that these are just some of the few measures that we have. So if you look at equity around the range of interventions that we have from pre-pregnancy, pregnancy, childbirth, and beyond, this slide shows you by these black dots the differences between various districts. So even the median values, the average values, do not give you the same story around the dispersion and the variation between districts in terms of coverage. And that's one of the big challenges that we have as public sector, program policymakers, and implementers around how we need to bridge this equity gap. This gap is also reflected with other measures that we have typically for equity, such as between various poverty quintiles. This is the way that we see for various interventions the differences between the rich and the poor. Now, this is good for an academic exercise. The problem with these measures is that they are of very little policy relevance. The Honorable Minister who is sitting on the stage at this point in time cannot potentially readily recognize where these poorest quintiles are living in a given population because they are not readily apparent. So recently, we looked at where the distribution of the two poorest quintiles was in Pakistan, and no big surprise, they are generally in the populations of southern Punjab and parts of Sindh and parts of Balochistan and KP, which we believe also to have the highest disparities in terms of access and care. I want to move on to solutions. And one of the biggest solutions in Pakistan that we have focused on is getting vaccines to our children. And here the government has been trying very hard, and it really is important for us to underscore the importance of this, not just for child health and survival, but also for eradication of diseases like polio. Let me make this case through an illustration of how much progress Pakistan has made in terms of getting access to major vaccines for its children over time. So if you look at rates of coverage of fully immunized children, we've doubled that over the last several decades. And while this may still not be at the rate and level that we want, around 80–90%, it is progress nevertheless. But it's unequal progress. So if you look at the distribution of immunization coverage in various districts, whether it is for changes in fully immunized children, there are parts of the countries that have been left behind. And much of the change over time, the doubling has been restricted to parts of Punjab and parts of Sindh and KP that you see illustrated here. There are also a very important policy imperative around linking routine immunization to polio eradication. So if you look at the current distribution of children who have never been immunized as just one sad measure, and they may not be huge, they may be 20, 30, 40% of various populations. And if I was to superimpose on this map the distribution of polio cases in Pakistan, and these are data from last year, but it doesn't take a rocket scientist to work out that these are the very areas where fully immunization coverage is at its lowest. So there's a very close link between what we are trying to achieve for both global security and polio eradication in Pakistan and what we need to do to invest in the health and immunization of our children. So let me try and conclude by illustrating what can be done. And a lot can be done in terms of promoting health, but it will require concerted efforts and it will require resources, ladies and gentlemen, and support to the government of Pakistan in making health, nutrition, and addressing some of the social determinants of health a priority in our national planning. So the first point to take home is that these high rates of morbidity and undernutrition in Pakistan also illustrate huge missed opportunities for impacting child development, education, and economic development. And this is a vicious cycle because high rates of child mortality are also an impediment to achieving our gains in population level fertility control, and also in promoting family planning in the very populations where we want this to be a major, major intervention. This is something that we can do. This vicious cycle can be interrupted. And it can be interrupted not just for addressing things in the short term. This is an intergenerational cycle of ill health, stunting, and gender differentials that Pakistan can invest in and should do over the next several decades. If you look at the feasibility of doing this, I think the grounds are very ripe. Pakistan has successfully scaled up some of the most ambitious programs of community health workers. Our Lady Health Workers program that the Honorable Minister will potentially talk about, the poverty alleviation programs, the income support program that we have that have huge opportunities for linking health and nutrition to such initiatives. Medium-sized pilot projects in various districts of Pakistan have demonstrated the potential for change and rapid gains. These models we now need to take to scale. And all of this requires resources, requires money. And we need increased investments, both domestic and also from our friends and donors, for investing in primary care and targeting marginalized populations in urban and rural settings. With the challenge that is emerging with the Sustainable Development Goals, Pakistan is well placed to accelerate its interventions to reduce maternal and newborn mortality, and we can potentially eliminate diarrhea and pneumonia deaths from Pakistan within the next decade if we put our mind to it. But it will require addressing inequities. It will require addressing disparities and reaching to marginalized populations through our existing and potentially future social safety nets. The new 10 points agenda that we have helped the government of Pakistan take forward as recently as in May this year, and is now being costed in various provinces, is a phenomenal step in the direction, in the post-devolution scenario, of translating some of this advocacy into action and to walking the talk of eliminating preventable maternal and child deaths in Pakistan within our lifetime. Thank you very much for your attention.